my distinct pleasure to invite Dr. Michael Mooney to come to the podium. Mike and I have been friends for, 30 years, and it's just wonderful to see him here. And Mike, you're going to tell us about markers of LV unloading and VA-ECMO, when to unload. Thank you so much.
Thank you. Good to be here and share some thoughts. I had a slide critical event, and so I have no slides. But I think I can begin the conversation. Perhaps, Bill, you can help extend it. So common in our understanding of ECMO is that it's bad, right? It always leads to toxic LV unloading. But is that really true? And among all of the parameters that are looked at, none of them are measured in terms of pulmonary wedge pressure, LV distension, and the fundamental mechanistic hemodynamic correlates have to do with pressure-volume relationships. The ECMO can be bad, but rarely do we measure effectively to know that we're targeting a loaded ventricle. And most patients have ACS, and at the same time that they're treated for their myocardial infarction, the LV is recovering. And oh, by the way, ECMO might not be bad because it resolves the acidosis, it improves the hypoxia, and by the way, pressure is good for coronary blood flow. So when you account for the changes that happen with recovering LV, improved wedge pressure, improved acidosis, improved hypoxia, the volume pressure curves, instead of being shifted entirely to the right, when they're appropriately adjusted for what's really happening real time, are actually less toxic than that. So fundamental to this talk is that you haven't unloaded an ECMO patient and you're trying to manage them. And when do you perform measures to unload? Well, that's a continuous occurrence, right? So that's medically driven unloading is central to any weakened heart, and especially for patients on ECMO. So if you look at that same modeling of pressure volume curves and you take the mean arterial pressure and bring it down to 65, you can see that the curves will drop to the left and improve. And that's your unloading when you do that. That's medical unloading. Similarly, because of the splanchnic shifts, the patients are in a volume overloaded state. If you drop the load, the preload, you diurese the patient. Again, the curves drop to the left in the pressure volume rendering. And so if you drop the load, drop the arterial pressure, and you diurese, you are, in point of fact, managing the patient. So when we speak of unloading, there's the feeling to jump to a mechanical approach, either an intra-aortic balloon pump or Impella. The commonly used metrics for an overloaded ventricle include a wedge pressure that can't be dropped below 25, an LVO outflow tract VTI of less than 10, which is a surrogate for our cardiac flow, and a pulse pressure maintained greater than 20, and screening somewhat for LV dilation. So if you have a failure in any of those issues and you've instituted medical unloading, then you're in the category of advancing to a intra-aortic balloon pump or Impella. But keep in mind, the data that we've seen thus far on ECMO and intra-aortic balloon pump, there appears to be some separation in survival over time, but this is incrementalism. And we're being asked now to think broadly in terms of breaking down barriers and a paradigm-changing intervention. And on the issue of unloading, it really does not appear to be that. And I'd caution a little bit, the language around unloading has transitioned to be that the axial flow pumps have a unique direct myocardial energetics effects independent of hemodynamics. And when you take that language and accept the pressure volume renderings of what Impella is, then everybody needs unloading. And I don't really think we're there. Current utilization rates for unloading for ECMO patients are around 60%. And there are complications, and worth mentioning it, because if you're going to put in an Impella system, the distal circulation is unknown, your iliofemoral system is unknown, and the possibility for causing ischemia is a very real issue. So you should have capacity for tissue oxygenation sensors. You should establish protocols for that. You should have familiarity with establishing an antegrade limb in that extremity, and you should have immediate access to helpful vascular surgeons. So it's not every center that can effectively implement an Impella strategy. Impella does seem to have an advantage over an intra-aortic balloon pump in that it does unload, and it additionally provides cardiac output. So I think in today's world, judicious, thoughtful management with a medical unloading for failure of that, then advancing to a mechanical support for further unloading is very reasonable. Thank you for your attention.
Mike, I think one of the dreaded complications of VA-ECMO, and I think all of us have probably seen this, is aortic root thrombosis. And we had a young patient that looked like they were doing fine, and all of a sudden they really started to go downhill, and we did an aortogram, and all the aorta was clotted, both arteries were clotted. And I just wonder how you manage that. It's not necessarily related to your talk, but do you think that perhaps the unloading by having a Impella catheter pushing blood forward out of the ventricle would help with that? What strategies do we do for that? Because that's really a horrible complication.
Absolutely. So in our center, we noticed an increased incidence of LV thrombosis and aortic root thrombosis for patients who are managed on Angiomax. So we no longer use Angiomax and use heparin. It seems like most of those, it's been a breakdown somewhere along the line where there's non-pulsatility. If you have an intra-aortic balloon pump in place, it can trick you into thinking that the aortic valve is opening because of the pulsatility there, but in point of fact, the valve is closed. And so from my perspective, that's a surgical emergency to evacuate the thrombus and try and be of assistance. It's very difficult to recover from it. I'd certainly invite other comments from the panel.
I mean, I think your point about pulsatility is critical. Any pulsatility, if there's no pulsatility, you really do need, in our opinion, to vent for those reasons. And once it's done, it's done. I'm not, our surgeons, once they clot off the aorta, they're not going to take the patient. We follow them closely by echo, just even to see if the ventricle is not decompressing or dilating, then we will certainly vent them, generally with an Impella, sometimes with even a 5.5 with the hope that we can transition them to 5.5 and decannulate them.
Have you seen any thrombosis after you put the Impella in? I mean,
no.
Okay.
Mike, what are your thoughts on partial flow ECMO versus full flow ECMO?
Oh, absolutely. Good point. So you modulate your flows on ECMO to suit the circumstances, and for non-pulsatility, dropping the flows can be of value. Low-dose dobutamine also is effective in getting some opening, but I don't think ECMO flows are a static phenomenon. They need to be dynamic to meet the needs of the patients, and it's incredibly complex to navigate all of the preload, ECMO, inotropic support volume status to get the patients through to a recoverable state.
So I think every VA ECMO patient should have a PA catheter in, unless they're super pulsatile.
So, this is also supported, but it's interesting how often it's not done, and it does seem to be really essential.
It's really a complex, everything we have is, we have what's the protocol, what's the algorithm, and, ECMO should have one, but it branches everywhere. So, your talk was fantastic. I think you really demonstrated how complex it really is. You unload them, but it could be you put them on ECMO, they get enough coronary perfusion that they start contractility, and their pulsatility is 30, 40. You don't need to you don't need to do anything else. Some you unload by giving them Lasix. Some patients will need an Impella, but if their lungs are poor, you put an Impella, you deoxygenate them. Maybe they need a transeptal catheter, and I think that is sort of where we are now, in that you need to think about it, and every situation is different. It changes. If the pulsatility goes to 0, you may need to put a device just because you don't want to thrombose the ventricle or the root, and I think your talk really illustrates that there's multiple strategies, and not every patient needs a mechanical device to unload. They need the thought process of, should we unload now? What is the strategies of unloading? Is it medical? Is it device? And what device? And I think without slides, you illustrated it very well.
We have a few comments.
Yeah, quick comment and question. I enjoyed your talk. I think the aim is to create optimal LV unloading, and I think time matters. And I appreciate you advocating for the pharmacologic management, which certainly plays a role, optimizing the pump speed, which plays a role. But I think we have good data that the greater duration of time to not achieve optimal unloading, it's a marker of increased mortality and morbidity. So I'd love to hear your thoughts on that time duration. I have my bias, and I'd love to hear the panel weigh in.
Well, it's a process that one of the things that makes it very clear that centers of excellence make a difference. You have to have 24-hour intensivist support, seeing the patient hour to hour to make these assessments. So I don't think an arbitrary timeline makes sense. But once you identify a failing loaded ventricle that's doing poorly, definitive action needs to happen in a timely manner. You can't put it in, forget it, and see how we are in the morning. That's a recipe for disaster.
Yeah, I think that's the key. I think it's within hours, maybe several hours, as opposed to waiting a day or two.
Oh, absolutely. Absolutely.
I think just a quick comment on your question. Dirk Westerman hopefully is going to be here tomorrow. Maybe he's already here, and he can update us on a randomized trial they're doing in Hamburg that goes to the question of timing, because I think what Mike said beautifully is, if your purpose is energetics and more getting the LV really recovered because you have no bailout after ECMO, it's a very different question than just, hey, let's get this patient through ECMO 3 to 5 days.
Just a quick comment, Mike. Great talk without slides. I think a food for thought is we need markers for wall stress.
Yep.
We need metabolic markers, and then we need, in the days of Mel Marcus, markers of closing pressure of endocardial small vessels. That's what we really need in a non-invasive way, because not everybody's getting a catheter, to really be able to make this decision scientifically. So food for thought.
Great comment.
I think this is a really important philosophy, that VA-ECMO is not a treatment tool, it's a bridge to something. And if we think about the load or unload, we're missing that opportunity, because unloading is going to make that bridge to some treatment, definite treatment. And if it's not a real biventricular failure, almost like 95% of the time, you can unload that with the Impella 5.5 and just wean the VA-ECMO even on the time of the implanting Impella, and then just another stage of the patient that you are, don't worry about the ischemia of the legs, and then you're ambulating and decide where to go.
Thank you. Thank you very much. Thank you.